get started.
There
On
you
behalf
go.
of Access to Integrative Medicine Health Institute and the GW Office of Integrative Medicine and Health, welcome to A Mindfulness Experience. AIM is a nonprofit organization with the mission to provide vulnerable and low-income communities with access to whole person health and wellness. The GW Office of Integrative Medicine and Health promotes integrative medicine by providing learning opportunities to health professionals and healthcare consumers. We have two very special guests with us today. The first is Dr. Kogan, Medical Director of the GW Center for Integrative Medicine and author of a new book, which I hope you'll tell us about, Dr. Kogan. We also have Nyle with us, Nyle MacFarlane. And Nyle is the founder of Blue Nile Therapy, an occupational therapist, and specializes in holistic manual therapies that consider the interplay between the mind, the body, and the spirit. So, Dr. Kogan, I will hand things over to you.
All right, well, I wasn't prepared to talk about the book because there's so many more important updates, but I'll mention something at the end, okay? All right, so let me start with something positive first. I think that's the right thing to do, and then we'll go talk about other things. So this is totally brand new. So AstraZeneca just announced that they had a very strong positive effect of their combination of antibodies called AZD7442. I'm going to put link to the study in the chat. Now, that's not necessarily approved medication, but it's already available in UK. And apparently, basically, it's not a vaccine. It's an actual live combination of antibodies that has been very effective at preventing COVID, including Delta variant. That's what they're claiming. Literally, this just came out a couple hours ago, so it's not even a couple of days ago. So I have to study it more, but it's very exciting. I got a message from my friend in regulatory affairs of the government. They're all like super excited about this because it may actually be a game changer, particularly for those who those who potentially breaking through the vaccine. If you start this early, it's probably going to work. So in essence, it's an active. Something like this is already on the market, right? So there are the active antibodies against the virus. They're a combination of several of them. So monoclonal antibodies that are mixed in different combinations. That's I think what Trump had when he had a disease. But this is a first trial showing prophylactic benefit because before it was only approved to do as the treatment in the early phases of illness. If this can be worked in as a prophylaxis after exposure or just at some random intervals, of course, that could be quite dramatically effective and used. Now, I don't know the prices, I don't know any of this, so stay tuned for more. And I don't think I can answer questions about it, so everybody can look up at the link. And then let me share my screen and we'll go through the local updates. So first of all, big thank to Dr. Axelrod for sending me the slides. Dr. Axelrod already presented to us once, and also she's the one who's the lead COVID response at GW, Medical Faculty Associates, so she shares these updates with us. I'm gonna roll through a couple of slides. This is a very interesting slide. It's just kind of showing us how quickly the science of effectiveness of the vaccine against Delta changed since late June. So kind of most recently, you know, we're appearingly seeing that the efficacy is waning. That's in top in blue, even though the earlier science back in July have shown already that there was some breakthrough cases and there is a rapid increase in breakthrough cases. It's still evolving. Most significant recent update, you've probably already seen this on August 18, which is 2 days ago, CDC and White House announced that anybody who wants can start getting a third vaccine on September 20th. So in contrast to what I intuitively thought is going to happen, the actual recommendation is get exactly the same shot you had before. So if you had a Pfizer, get a Pfizer, get Moderna, get Moderna. If you cannot get the exact one, get the still mRNA. So if you had a Pfizer, get Moderna. If you had Moderna, get Pfizer. If you cannot get exactly the same. There's seemingly no evidence currently to say that what if you had a Johnson & Johnson, should you get a Moderna now, or should you get another Johnson & Johnson? There's no good answer to that yet. So I'm not exactly sure what they're going to recommend. This recommendation particularly concerns only people who've gotten mRNA, either Moderna or Pfizer, okay? Officially, there has already been approval for anybody who's immune compromised. Now, how do you exactly position someone? Well, there's a list of conditions that listed any active cancer or treatment for cancer, dialysis, organ transplant, or anybody on any kind of immune suppressive medications. They did not include other groups. So for example, in people over 65, even though vaccine efficacy declines pretty quickly after 6 months, they decided not to yet start vaccinating this group until September 20th. But after September 20, basically, the doctor can make a recommendation and anybody can get it. So if you really, really want to get it, then on the September 20 or after, we should all be getting opportunities to obtain the boosters. We talked a little bit about strategy of should we do the tests first? Like, let's say if I test myself and I have a very high antibody level, and then maybe I should skip the booster. Nobody knows how to address this well, because negative test doesn't necessarily mean there's no protection. The tests are not very good at picking up continuation of an immune response. So if you're positive, that's good. And if your level of antibody is high, that's probably suggestive that maybe you can wait on a booster. But the negative, meaning if it comes back no reaction, it doesn't necessarily mean you're not protected. So it's really hard to figure out whether ordering tests makes a lot of sense. I think it needs to be done on an individual basis. I don't think there is any blank recommendation at the moment, or I'm not even sure there will be any recommendation, mostly because the tests are no good. That's really the answer. So that's that. So this was published back in the day. This was the original study that was showing a very good protection. This was an Israeli study, I believe, even though it was published in the American journal. But you can see that here. Are you guys seeing my mouse?
We can see it, Dr. Kogan.
Okay, good. So you see this is the level of protection. So if you had nothing, it's just at a placebo, the chances of probability of getting COVID was basically just linearly increased. But whether you had a low level of titer of antibodies in the blood after that's checked or high, the difference was a little bit, but not very big. So that tells you that the tests are really crapshoot. So using the test to figure out whether you're in a high or low category, it's not very, very effective. Even though there was a small statistical significance between low and high and moderate, but it's not, clinically speaking, this difference is just too small to worry about it. But now the caveat to this is May 17 published. So this is pre-Delta in essence. So is the Delta changing this? I don't know. I don't think there's a good answer. Okay, sorry, I got to scroll. It's not a PowerPoint, it's just PDF. All right, I'm not going to show you everything, but this is important data showing that basically in short is that those who had a second vaccine had a much significant, compared to placebo, they had way more likely being protective. We already knew this. Interestingly, that this particular data showed that even after 146 days, if you had 2 shots, there's almost no drop in terms of the protection. Even with the 1 shot, you're just less protected, but you're not really dropping off. In 146 days, that's whatever that makes it. So that's an important data showing that if there is a drop, it occurs later, and it's probably not linear. That's what the data show. We already kind of knew that, but it's good to have more and more studies coming to support that. I think I'm gonna skip this. This is some of the breakthrough. What's really important is that when the breakthrough happens, you don't have poor outcomes. We already talked about it. So basically, you're looking vaccine, no vaccine, and no vaccine. The poor outcomes occur if you get infected way, way, way higher. So We can make this probably accessible to people if needed, although it's very detailed and very pro-doctors oriented. So this comes up all the time. I think that's why Dr. Axel decided to include. Even I got on the radio, I got this asked last week. So if we get everybody vaccinated, does it mean we're gonna have more mutations, right? Because like if you're taking more antibiotics, does that mean we're gonna have more superbugs? So interestingly, there's no easy answer here. So one way to think about this, no, the virus is not going to mutate because vaccine is given. That has nothing to do with that. But virus will mutate no matter what. And the virus will pre-select a type of strain that's going to be more resistant or more productive, if you will, or multiply faster in those people who have the vaccine. So in some way, we're not necessarily making virus mutate any faster, but we are selecting more resistant mutants in essence, when unfortunately vaccine is not blocking the transmission. So that is important to understand, that we're not, Delta is not the end. That's what this means. Delta is just the beginning, and it appears to be clearer and clearer that we are going to be with all of this for a long time, unless there's some really effective intervention comes that can prevent transmission and active disease completely. Is AstraZeneca's new med a harbinger on more such treatments to come? I sure hope that's true, but I think it's too premature to state that. So no decline in vaccine effectiveness observed after 24 weeks. Very important. This is very fresh data. This is collected data between March till the end of July 2021. This is the CDC published data. Again, this does include some Delta, although not all of those was Delta, because obviously when this was started back in March in US, the Delta was just coming in. We didn't have it yet. So that needs to be taken with grain of salt. All right, I'm gonna skip this. This is too complicated. All right, so who needs an additional COVID vaccine? We started covering this. So anybody immune compromised, but if you're not formally immune compromised in that list, okay, who else should be getting it? Well, you know, you could look at this list, even though patients with advanced or untreated HIV were not originally listed in that category. Now they're added. Anybody, corticosteroids are considered immune suppressants, so they should be added. Anybody who is on steroids, and I would expand that even further. I would say, to me, high dose equals more than 40 milligrams a day of any, or of prednisone or any equivalent. So, you know, those are the patients who should get vaccinated now. Again, after September 20th, you know, if you're totally immune competent and you're not over 65, that decision becomes a little bit murkier. It probably depends heavily on when you were vaccinated, but it's pretty clear that there's going to be a very aggressive push for the boosters in first line healthcare workers right away, especially since most of us, myself included, been vaccinated back. My first vaccine was last year, so, and second vaccine was in January. So I'm already 8 months out. Now, chances are I'm probably still protected, especially knowing that personally, I tend to generate very strong immune responses to all the vaccines, and I've tested some of them over the years, and that's why I say this, although I did test myself recently for the antibodies, and they were positive 2 weeks ago. Even though, again, I don't recommend using that for the decision of booster or no booster, but positive test could mean hold off of the booster. That's how I read it. Okay. What are we doing on time? 18. I guess I think I have. Yeah, we talked about this last time, so we still have this trial ongoing. So if anybody really desperate to get a booster, go ahead and contact GW trial, and they will enroll you. But other than that, if you're not in the immune compromised category, you're gonna have to wait till September 20th or later. Okay, And this is, can vaccines be mixed? So if possible, use the same, but if not, use the other. What about eligible people who got J&J? Well, this is not really, there's no data, as I said, there's just it under review. So, and this is why the things that have been slow. The CDC basically is really afraid of causing kind of a, they basically waiting to collect more data on safety of a third injection. That's why we're seeing a delay by many weeks, because there's a desire to say, look, we have looked at enough data points to say that there is no serious side effects after the third shot. But there's just no published data just yet. And it's quite plausible that the third shot, especially in those who had a pretty bad reaction to the second shot, that the reaction to the third shot is going to be not pleasant. So that needs to be taken into account seriously. And I think that's it. Anyway, this are the other medications that were used. Now, what I said about AstraZeneca, that's brand new. But this is the same principle. The sum of these medications, this one is no longer even offered. But unfortunately, the efficacy seems to be very mixed and unpredictable. So with that, I'm going to stop sharing, go to question, go up, and I know there's a lot of questions. So, Ellen, yeah, that cannot be true. None of the vaccines can induce COVID. She may have been infected and had COVID despite the vaccine. That's possible. I can't speak to her decision of declining the shot. If it wasn't a COVID, then it could have been a severe reaction to the vaccine. I mean, I guess the general recommendation would be still get a second shot, maybe get it much later than the first, standard recommendation of 3 weeks. But I think trying to see if I can answer better this question. I don't think I can. Okay. Booster question from Benita. Who's been told to get it 8 months after the second? We are being told. Nobody knows. What I will tell you that the information I'm giving you right now, probably it's always going to be a few weeks ahead of anything that comes out of CDC. So we're going to be a little bit ahead of them because they're always a little behind. We analyze our GW team analyzes data in real time, and so it can communicate with the faculty and patients a lot faster. So this is just one of those strange situations where we're still waiting for CDC for official guidance, but a lot of the data points and information comes out ahead of time. But for this, nobody actually knows. In healthy healthcare workers, at 10 months, there was still 90% protection, regardless of the Delta, because the Delta, whether it's 2 months or 8 months, the efficacy of Pfizer specifically, or most, is just not as good. But that has more to do with Delta, not with the general efficacy. And with a waning of efficacy after many months. So just get that clear. So I'm not even sure that anybody knows exactly at what month's point should you be getting it. I will tell you, my practice is going to be like this. Anybody over 65 with comorbidities, I'm going to push for boosters very quickly. If after discussion, there's an uncertainty, I will potentially check labs just to look for positives. So if it's positive, we can wait a bit longer, only for that reason. So I may end up being guided by the lab, but I'm not going to be guided by negative labs. If the lab is negative, it means nothing. We're still sort of unanswered, uncharted territory. But for most patients who are okay getting boosters, we're just going to recommend them. And it wouldn't matter whether it's been 6 months, 8 months, 10 months. It has to be 6+. That's what it's pretty clear. Now, what happens after that? Remember, the current boosters, not even taking Delta into account. There haven't been a suggestion that the new boosters gonna have better coverage against Delta. That's in the workings. So I'm assuming a lot of people gonna wait for those boosters that are gonna cover the Delta better. And I think that potentially could be quite reasonable. Okay, there was also a question from last meeting about mixing of vaccines to, yeah, so that's what that was my sense, but it doesn't really panning out to be true. The recommendations are not to mix them. So like there's seemingly just no data yet to suggest that, but there is several trials of crisscrossing of vaccines. So I think the data will be in upcoming weeks. Yeah, CDC stopped tracking breakthrough cases. They basically government ordered them to do it again, I believe. So I'm not exactly sure where that's going to land. But Linda, there's a constant trials on that. So the data been gathered at large entities like Mayo Clinic and certain locations. Like there's a consortiums of data gathering in New York and Boston. I don't know, but I don't think there's anything here in DC. But there are several areas around the country where academic centers kind of came together. So they're putting the data together and they're continuously analyzing it outside of the federal, federal level.
But Dr. Kogan, is that only analysis of cases that actually get into a hospital?
No, any reported cases. Because the reporting gets tracked. The moment COVID diagnosis goes in the chart, most of this data is now through the electronic medical record, so it gets quickly gathered, and there's a continuous real life analysis of the charts in essence. But I don't know if I can say more to that, because in reality, at the end of the day, mostly what we can look at are the published or pre-published, the MedIRX data. Beyond that, unfortunately, but some of this data, like the slides I was sharing, some of the data is like literally real life. Some of the articles came out like a week ago, and their analysis is based on just a week or two before that. So it's pretty quick. It's definitely quicker than what CDC can do. I mean, there's no question that some of the academic centers, their speed of gathering of data and setting it into the public eye has dramatically increased the speed. Usually it used to take weeks, if not months, to get peer reviewed. So some of the studies, it may take still weeks and months to get peer reviewed, but you see the data, you can make a decision for yourself. So it's pre-published, but it's already open to public to see.
Misha, will you send me a copy of the PowerPoint?
Sure can.
Okay, good. And I'll share it with everybody.
I don't know if it's a good idea to put it online. So I'm not sure how can we just.
Okay, never mind. It's just a thought.
I didn't ask Connor for whether. Post it, but emailing it, I think it's fine.
Okay.
So you let me know, okay?
Yeah. I may reach out to her and ask.
Mm-hmm. Okay. Let's see. Oh, thank you, Nancy, for saying this. I didn't know that. Actually, that's not the information we got on Thursday, but I guess maybe they come in waves. So if anybody else calls the GW trial, maybe they'll allow more people in. But thanks, Nancy, for saying that. Looks like the trial is full already. Sorry. Okay, Elizabeth has a good question. If one had COVID in February last year, are you sure about that? Because that's when the tests were not even ready yet. Okay, so let's assume that's true. Then got double vaccinated by March of this year. Did the third exposure with the second shot boost my immunity 10 times as if another person got double waxed? Great question. Nobody understands, but there's a belief that the vaccines after active COVID are generating way stronger immunity than in those who did not have the infection first. So it's hard to say here whether you should get a booster. This may be the good case to try to do the lab. The the problem here is, well, not just do the lab to the vaccines, but also do the lab to the non-vaccine virus. So do every available lab through the insurance covered commercial approach. But that's a hard one, because there's an anticipation that probably the immunity from March is going to last you minimum for 8 to 10 months. So you're probably okay for quite some time. So I would rather probably, in your shoes, wait for the specific booster against Delta rather than go and getting another one now. Okay, any new evidence studies on long COVID Delta in the vaccine? No, I don't know. Elisa, thanks. Let's keep an eye on this. I think that's a really important question. I don't have anything to add to that though. Okay, we're at exactly half hour. Let's see what else left. Elizabeth, you want to hold on to your question to next week, your second question, because it's more specific. I don't want to.
Sure, that's fine. Fine.
Misha, were you able to answer Sheila Clark's question?
Oh.
She has her hand raised.
Okay, Sheila, let's do your question, and that'll be the last one, okay?
Okay, I didn't really have a question. I just had a comment.
Go ahead.
In the future sessions, can you get back to building our immune system up? I know earlier on you talked about supplements and all of that, but I think we need to revisit that because, we're feeling kind of naked here relative to what we can do personally to help ourselves against now, which is a stronger variant of the situation. So if we could have some more talks on how we can help ourselves and have a better immune system, as opposed to the people who are not doing what we're doing. You know what I mean? Can we get back to—
let's take this and Tatiana, let's take this, and Jan, let's take this into consideration and let's figure out how we're going to do this. Maybe one way I could do a quick review in the next couple of sessions, and then maybe we should restart having some of our speakers who came before and did this to do this all over again, because I completely agree with Sheila. I can't keep things in my head.
We can definitely do that.
Yeah, I think it's really good when as of fall as winter is coming. So thanks, Sheila. It's a very good.
Thank you.
All right, with that, Elizabeth's gonna hold off to her question till next week, and it's exciting. Nyle is back.
Hi, and maybe I can help with Sheila's question a little bit. We'll see. So my name is Nyle, and I do specialize in chronic illnesses. So a lot of patients who come to see me have kind of been through the ringer. And by the time they get to me, they're in debilitating chronic pain. They're stuck in pain cycles. And a lot of it comes back to the fascia. So I'm going to talk about two things today. The first one is fascia, because I think a lot of people don't know what that is, or if they do, they don't have a full understanding of it. And it's totally understandable because up until 2018, the medical community didn't even recognize it as its own organ. So I'm going to share a slide with you. It's going to be it's in vitro, meaning it's a real life slide that was taken from a real living person through a camera through a scope. So, just a little content warning, it might have some, viscosity to it and some blood and all that good stuff. So if you're not sure you want to see that, I suggest maybe covering your eyes, and I'll give you a warning when I show it. The second thing that I really want to convey here is that the body does store emotion and trauma. So raise your hand if you know that's true. Okay, we're not doing too bad here, 50-50. That's way better than when I first started practicing, over a decade ago. My patients were like, I'm sorry, Nyle, I just don't believe in that woo. So we're getting better. And I do think a lot of it is thanks to our diagnostic testing and our ability to go into the body and see what's truly there. So it starts with fascia. And to answer Sheila's question, why do you need to care about this stuff? Well, the reason is because if we are not accessing and opening the fascial webbing inside of our bodies, we are creating stagnation of the tissue. And what do we know about stagnation? stagnation leads to illness. It leads to chronic illnesses. So Dr. Kogan, I would actually venture to say, I don't think it's just, the electromagnetic storms or anything like that. I think that we are, as a society, in a place where we have been stagnant for almost 2 years now, you guys. Almost 2 years. Our occupations have been stripped away. We've been forced to sit at a computer and do our daily routines with the forward head posture, and that's creating stagnation in our tissue. In fact, in the last time I was here, I talked about something called dead butt syndrome, where your butt literally dies out from underneath you from all the sitting. So all of that has an effect on your fascial webbing, and I'm going to show you what all of that is now, and then I'm going to tell you what you can do about it. So if you really want to start to change your immunity, start here, okay? And then everything else you do will start to get in. The food you eat, the meditations you do, the exercise you practice will be more effective because you're creating flow in your tissue. All right, are y'all with me so far? Okay, good, lots of bobbing heads. Okay, all right, so Tatiana, if you could go ahead and share that first slide now. I'm gonna show everyone the fascia. So this is the content warning I spoke about. This is really exciting because Jean Gambartu, who is a plastic surgeon, he figured out a way to record living, breathing fascia. Up until his work, we were only ever able to see dead cadaver fascia. And once the fascia is dead, it kind of just looks like, if you ever eat beef jerky, like old school beef jerky, and you rip it apart, that sound it makes, the stuff that is kind of pulling the beef jerky apart, that's fascia, but that's dead fascia. And that's the fascia you end up with when it's sticky and dehydrated. However, when it's still in your body and alive, this is what it looks like. And so you can see here on the slides, it's actually very viscous, otherwise known as lubricated. And inside of those little strings, it's actually hollow. Those are microtubules, almost like telephone wires that conduct information between what they're connected to and what is up against that connection. So let's say in the top left-hand corner, for example, up here, let's say this is fascia that rests along a muscle, and it compartmentalizes the bicep muscle and keeps it separate from the bones. So this has to be lubricated and open in order to allow for the bicep to slide and glide along the bones. And then if you go down here in the bottom right-hand corner, for example, let's say this, yellow looking stuff here is probably adipose tissue or fat tissue. So let's say this is fascia that surrounds the intestines. And when it surrounds the intestines, it's known as viscera. So let's say this tissue down here is the viscera around the intestines. See how it's very open and lubricated right now. If it was dry, if it was thick and dense and dehydrated, then what it is surrounding wouldn't be able to mobilize or move. And every organ in the body needs to have movement. It's known as motility when it moves. So if the fascia is sticky, the organ loses motility. And if the organ loses motility, that organ then can't pump life through. It can't beat, it can't move food through, it can't do its job. So it all comes back to fascia. The last thing I want to tell you about fascia right here, if you look on the right-hand side, these are all the different names of what you'll know fascia to be. The mesentery is the fascia that covers the intestines. The dura mater is the fascia that covers the spinal cord. The dura mater covers the brain. The dural tube covers the spinal cord, and the pleural cavity covers the lungs. Do you think those are important structures in the body? The extracellular matrix, this one is really exciting because that's the one that was actually discovered in 2018. where scientists found that through the process of technology, they were able to look inside of the nucleus of the cell. And inside of the nucleus of the cell, they found fascia. So Tatiana, you can go ahead and unshare this one for a minute. Why this is relevant is because at the end of the day, we are made up of fascia down to the cellular level. So if the fascia is not open and conducting information, our cells are not functional. All right, do I have your buy-in now on why this is so important? Okay, good, good, good. All right, so great. Now, how does that result in holding stress and emotion? Well, have any of you read any books on how the body stores trauma or emotion? And if so, could you type them in the chat there if you know of any books at all? And for those of you who this is new information for, maybe this will be a great jumping off point for you to start to understand this mind-body connection. So The Body Keeps Score. Yes, that is the most popular one by Bessel van der Kolk. It's probably going to pop up there a few times. Another good one, I'll type it into the chat. Yes, Chasing the Tiger. Thank you. That was the one I was going to type in, by Peter Levine. The Body Bears the Burden. Beautiful. You all, thank you so much. I'm going to suggest just one more that may not be on your radar. It's called The Elephant in the Brain. And I can type that in the chat too. Okay, the transformation, excellent. So Molecules of Emotion, thank you, Suzanne, that's a really good one. My Grandmother's Hands, also a really good one by Resmaa Menakem. That one talks a lot about somatic and like cultural somatics and how racism actually gets stored in white bodies and Black bodies. This is so good. I am so impressed. I have to tell you, 10 years ago, I never, this was not the response I got at all. So I'm very, very grateful that this is starting to become on people's radars. Now, I want to take it one step further and talk about something that even these authors don't talk about, which is not just the fact that trauma and emotion is stored in the body, but specifically why. All right. I showed you the picture of fascia. You see that it's these beautiful tubules, these great conductors of information. Those tubules inside are hollow, but they actually, just like the rest of our body, store fluid. So they're fluid filled. And inside you have little DNAs floating around. And all of that contains information. That's why generationally, we inherit our family's trauma, because it's stored and passed on generation after generation in the fascia. And then it becomes our posture. That's also why oftentimes our posture mimics our parents' posture. Our chronic pain patterns mimic our parents' chronic pain patterns. I treat generations. I'm a pediatric OT by training, so I treat children and I treat their parents. And I see this in the clinic historically. So Tatiana, if you can pull up the other slide now, I can show you a little bit more about how the body stores trauma and emotion. So emotions and the physical body. The number one takeaway here is the emotions go to the site of greatest restriction in the body or greatest resistance. So if you have places in the body that are constantly in pain, that are your chronic pain places, they become like a sponge for your stress and emotion. And that's what keeps you stuck in a vicious cycle. The body needs flow. I'm just going to read to you something here on a pamphlet that I'm going to show you next, which is about understanding your organs. The body retains the memory of trauma, whether it's physical or emotional. In intense stress situations, the brain passes the excess stress onto the organs, whose fibrous matter immediately records the emotion. This sets off a psychosomatic reaction. The human body is the seat of a permanent emotion, organ, behavior, organ cycle. So emotions go to the organs, then the organ becomes that behavior that the emotion stores. And I'm going to talk about that next. The last point here is the viscera and emotions. So Tatiana, you can go ahead and unshare and I'll show you about viscera and the emotions. So viscera, as I mentioned, is what fascia is called when it surrounds the organ. Every organ in your body has a function, right? Every organ in your body also has a movement. They all move. That slight movement is what keeps them functional, okay? And I am a fascial specialist, so I have every organ's movement memorized. And my job when you come to my table is to help jumpstart that movement in the organ for you again so that it can function. Now, one of the things I'm trying to teach in this new virtual world we're in is how patients can start to facilitate and jumpstart their own movement and their own flow. Maybe not organ specific necessarily, but more body, more globally myo or muscle fascial specific. The one thing I will say about the organ specific though is even if you can't feel for the movement, you can increase your awareness around the things I'm telling you now. So if you have an organ that tends to be kind of your, I don't want to use the word problematic because words matter, but the organ that's often on your radar, the one that you're often dealing with, then there's probably something to that. There's probably some emotion and undealt with karma there. So I'd like to help you out with that now by bringing that awareness to the surface. Does anyone have an organ specific that is constantly on the radar? Something that maybe they're constantly having checked at the hospital or with their healthcare professional or wellness professional, something that has like inherited, you know, you're always writing down on the medical forms. It's like something that your father and your father's father and your father's father before him has dealt with linearly or lineage wise. This could be like heart disease, so lungs, cardiovascular, pancreas, liver, spleen, kidneys, anything, right? We have eyes. So throw in there a few more, any organs that you've just have been on your radar your whole life. This could be breast tissue, this could be stomach, digestive, kidneys, brain, lungs, anything. Good, good. Thank you. IBS, intestines, absolutely. Colon, liver. Eyes is coming up a lot here. Maybe I do need to talk about that one. Digestive. So I'll talk about digestion. What I read off of when I was showing the last slide is this little pamphlet here, and I don't expect you to be able to see, but this is something from the Barral Institute. Jean-Pierre Barral is a physical therapist who created the method called Visceral Manipulation. And that's one of the things I'm trained in. Visceral manipulation is releasing the fascia of the organ. And in this great little pamphlet here, he talks about all the different organs and the function, the motility, all of that, but he also talks about the emotion that's stored in there. So I'm going to share with you the emotion that is stored in the intestines, and I will talk about the eyes, but I want to add a little disclaimer here. I may, oh, I'm good on time actually. And let me know if I'm talking too fast, by the way. I'm trying to cram it all in as usual. So before I talk about the emotions of these organs, I just want to give a little trigger warning here. If you are feeling emotional from this, and emotional could be angry, frustrated, denial, grief, relief, those are all different emotions, right? Not good or bad, just emotions. We're going to take away the judgment. They're just emotions. If you feel an emotional charge around what I'm sharing, there's probably something to that. And now we know all that means is that's in there. And I'm going to show you how to bring it up so that it doesn't take over your life and keep you stuck in that chronic pain pattern. All right, so let's talk about the intestines first. Are you all ready? According to Jean-Pierre Barral, the emotions that are stored in the intestines, and this includes the large intestines and the small intestines. This does not include the stomach, that's a separate organ. The emotions are tendency, oh, and these can also be behavioral patterns because it keeps you stuck in these behavioral patterns. Tendency towards exaggeration and theatrics, slightly obsessive, certain rigidity, rigidity meaning stuck in your belief systems, mood swings, insensitive and thin-skinned, inclination towards paranoia, and great generosity, very giving. Okay, so that is somebody who has fascial restrictions in the large and small intestines. Those are different behavioral patterns or karmic patterns that play out in those in those people. Now, the stomach is slightly different. People who have fascial restrictions in the stomach organ, someone who's constantly getting the stomach, which includes the duodenum, which is leading into the stomach. If you have restrictions there, it's often social stress or fear of loss of stature. What am I doing? What am I not doing? You know, constantly stuck in that pattern. What am I doing? What am I not doing? Appearances and self-image, the power of extroversion, they're very extroverted. Poor self-esteem, lack of self-confidence in childhood specifically. Marked ambition, they take action. They sometimes are like overactive. Unstable with arrogance or altruism, fear of or inability to bear failure, feeling powerful or, feeling powerful to self-deprecation, spontaneous anger, and they need a lot of extra time to get over strong annoyances. All right, I'm going to do the eyes, but let me talk really quick about breast tissue because I think that one's really important. I work a lot with breast tissue around releasing stagnation around the breasts. That carries a very maternal caregiver sort of karma to it. It holds a lot of guilt, a lot of feeling like taking on the responsibility for the household and for the family. There can be a lot of grief and sorrow and loneliness in the breast tissue. Unfulfilled wish to have a child, feelings of guilt and failure, submission, shyness, difficulty finding your place, and some relationship and instability with the mother. All right, let me talk about the eyes really quick. That one's not actually listed on here, but it is one that I work with a lot. And you'll be, this might be helpful to know, it's not actually the fascia of the eyes where the restrictions lie. It's fascial restrictions in the base of the skull. So if you're having a lot of eye pain or diplopia, like double vision, or kind of movement, nystagmus, where the eyes kind of move around, it's often because the back of the skull is restricted. It's the base of the skull, the occiput, that holds the cranial nerves that control the eyes. Okay, so you want to create movement in the back of the head, and I'm going to show you how to do that now. So in these last 5 minutes or so, for those of you who would like to join me in this, we're going to move. Now, I want to say, we've been sitting and you've been listening to me this entire time, but there's a ton of value in the awareness factor and just increasing your awareness that the body does hold emotion, and specifically in those organs. Oh, sorry, let me speak to the karma of the eyes. The karma of the eyes often has a lot to do with identity, okay? Making yourself small, making yourself not seen. And if you're having, stuff going on around that right now, it's because you're either shifting into a new awareness around wanting to be seen, or your body is just tired of being in that state. So if you look at the posture associated with this kind of crunching your neck and the head down in to make yourself small versus being big and open and tall, that has a lot to do with identity. So the eyes have a lot to do with identity and being seen in the world. Okay, So again, I'm going to just say if any of those lists of emotions resonated with you, it's probably because that part of the body is like, oh my gosh, they see me, yay. And so much of this is just about the recognition, acknowledgement, and awareness. And then beyond that, bringing movement and breath into the body. So starting today, I have a challenge for everyone in this group. I'm going to post this link because it was shared a little earlier up, but then there are a bunch of questions. So I'm going to share it again now. In the chat here is a link for a body scan worksheet. Please open it up. I'll even give you a second. Open up this link and print it out, because after today, you won't have access to it anymore. It's not publicly advertised on my website. This is something I only offer to people who work with me through my coursework. Now, if you are interested in working with me and in more depth, if you're like resonating with all of this and you really want to go deeper with understanding how to treat your body, I am doing a free or donation-based pain relief clinic in September. The dates are September 17th through September 20th. That is on my website, which is blueniletherapy.com. I'll type it in the chat too. And then you can probably find this on the recording and stuff later. blueniletherapy.com. If you go to the events section, you can see it's a free or donation-based clinic all about relieving pain. And you'll get access to this worksheet again, along with some other ones. But what I teach people is how to move intuitively and reconnect with the parts of the body that are stuck in chronic pain cycles and how to break through. And I'm going to show you a little bit of that now. So go ahead and open up that worksheet. And I'm going to open it as well. And if I can share. No, I won't share because I want you to be able to see me. Never mind. Okay. So if you have the worksheet open, you'll see that it has a figure of the anatomical figure on it. And then at the very bottom, it has a list of questions that you can ask of the body. Here's your homework assignment. Every single day, you are going to get up in the morning. You're going to put on some music instead of the news and instead of your phone. Okay, Dr. Kogan? You're going to put on some music, preferably music that makes you want to move. You're going to pull up this assess worksheet and go to the bottom where it has that list of questions. Then you're going to begin to move your body and scan your body and ask those lists of questions. And I'm going to give you some ways that you can move now. And for those of you who would like to do this with me, I invite you to stand up and do this with me. You don't necessarily need to see the screen. You can just listen to my words. And if you don't feel like you quite have a handle on what I'm going to show you now, you can also find a video of this also on my website. So blueniletherapy.com, under the resource page, I have a video of jiggling and a video of unwinding. So you can watch those, but I'm going to show them to you now. So if everyone has that sheet pulled up, go ahead and stand. Take a slow breath in, a slow breath out. Soften your knees, soften your hips, even put your hands on your hips, and then just start to kind of bounce. Pretend like your knees and your hips are springs, and then begin to sway side to side a little bit. Take a slow breath in, raise your eyebrows up. A slow breath out, relax your eyebrows down and scan your body for what is not moving. And that's one of the questions on the assess worksheet. Wherever in your body is not moving, I now want you to start to jiggle there. So for me, it's my neck. And Sheila, if it's in between your eyes, you can raise and lower your eyebrows a couple times. Also put your hand on the back of your head and see if you can just create a little movement in the back of your head. And those of you who typed in an organ, I want you to place your hands on that organ now. For your stomach, it's on your left side under your rib cage. For your intestines, it's right under your belly button, maybe even a little lower. You could put your hands on your chest or down at your organs, your pelvic organs, if it was your reproductive organs. Let me see if there's any other ones. The liver is on the right side under the rib cage. So scan your body, and any place that's not moving, I want you to just start to jiggle there now. So movement is the first way to create flow in the body. And through this movement, we're actually breaking up superficial fascial adhesions. The way this works is the body is, let's say, 60% water, give or take. When you begin to jiggle, you're disrupting the water in your body. And imagine now if you had music on in the background, and try to find a beat. So start to move to a rhythm, pick your own, and make that movement a little bit bigger. Bring it down into your arms now. This is why we need music. Now, if you have a rhythm, imagine what's happening inside of your body to that water. It's picking up inertia and it's crashing against those tight places in your body. I want you to bring awareness to a tight place in your body again. And imagine that water crashing up against those fascial adhesions around the spine, or the organ, or the eyes, or the back of the head, or the shoulders, or the hips, and bring that movement into that part of that body with intention. I'll repeat again, the stomach is on the left, the liver is on the right, underneath the ribs. You can start to just move your hips and move your ribs. And these are all things I'll teach you a little more specifically in that pain relief clinic. But just for today, I want you to know this is yours and it's available. Now come to your breath and slow down the jiggling and start to turn it into wave-like motions, bringing your arms up. Come into the center of your spine and start to move your spine very slow. You can start down in your pelvis because that tends to be a little safer for people. Move your pelvis and your hips. And then start to bring that wave and that movement up your spine a little bit. And now here's the next question. Where is the pain? So this is another question on your assess worksheet. Now begin to move all around the room. So step away from the screen and challenge yourself to move your feet around the room a little bit. Stay with that slow, fluid-like movement, letting it derive from the center of the spine and out into your arms and legs. Now, another question is, what is not moving in the body? And whatever's not moving, I want you to move from there. Let all of the movement originate from there. So if it's the neck, move the neck and start with the neck. And then add an arm, another arm, your face, your torso. And then the last question we're going to do here is, what's connected to the place that's not moving in the body? So if you have the neck, what's connected to the neck? Whatever place that is, start to move that place now too. Take another slow breath in, slow breath out, and breathe into that space you're moving. You can begin to slow the movement down and come back to the screen if you're not already. Now, if you're doing this on your own, when you do this on your own, you can actually write on that worksheet what came up for you. So my suggestion is look over those questions at the bottom and use those two techniques that I just showed you. They're called rebounding and unwinding. And you can find the video tutorial on BlueNileTherapy.com. And if you'd like more guidance around how to move in ways that are a little bit more mindful to the body, keeping in mind that not everybody's body moves the same way, then I am offering a pain relief clinic in September. So you can find all that information there. Okay. Lots and lots of resources for you, but really just move and make it a daily practice. This can be a 5-minute thing, like 2 songs.
Niall, Linda's asking if you're breathing through the mouth or nose.
So with the breath, that's like a whole separate thing. I would say breathe in through the nose, breathe out through the mouth. And this is just about noticing right now, Linda. Notice what feels tight, okay? Oftentimes the breath feels very tight because of the fascial restrictions. And then we start feeling really frustrated around that and we try harder, and trying is the opposite of what this is about. It's about noticing. The body wants recognition, right? In through the nose, out through the mouth. Don't worry about the rest. If you find yourself overthinking, go back to one of those questions. Those questions are specifically designed to get you into your body and out of your head. Thank you for that. Yay. Okay. Oh, and one last thing I'll say is if you're noticing more now, like my knee is kind of feeling a little tweaky, that's the stuff coming up that's already in there. It's the stuff coming up to be healed. So the way through that is to move a little bit more and move a little bit more slowly. And then the next step is to self-treat. And again, all of that's covered in this pain relief clinic. So, and I'm sure I'll be back to talk about this another time later, but this is just kind of introduction stuff.
Thank you, Niall. Sorry, everybody, we went a little bit over, but I think 5 minutes is okay. So yeah, enjoy wonderful weekend. Janet, do you want to give a preview? Oh, I promised the cannabis book. I forgot. Okay. Well, I hate bragging about this, but anyway, so I'll just put the thing on a screen. You can actually, never mind, I don't mind putting on. So it's basically a general book on medical cannabis. It's called Medical Marijuana, Dr. Kogan's Guide for Evidence-Based CBD. I forgot what the whole name is. Anyway, if you just Google my name and medical marijuana in Amazon, I think it's the first thing that's going to come up. The book will be released on the 26th of October. We're in the middle of doing Audible, which is pretty fun process, actually. So I'm driving to New York, not this next Friday, Friday after, to do introduction, and we'll do some other parts. So there's a pretty cool professional actor that is doing the rest of the book, and I'm trying to get Dr. Weil to do the intro part or preface on his own for the book as well. That part is actually quite fun because I get to talk to the artist and to my co-author. We're kind of doing it all. So it's apparently the standard now. So the Audible comes at exactly the same time. So there will be a little bit of my voice in there. I think it's a good general read. So if anybody want to pre-order it, go for it. Thank you so much, Tatiana, Tati, for putting it in the chat, by the way. And it's a very practical book. So the whole idea always been not to go in a lot of theory, but really be, okay, you have chronic pain. How should you start and how do you should use the cannabis for that? So it's very, with case reports, with very specific instructions, start this product with this dose, titrate it this way. And if it doesn't work, then there's a next step. And, you know, I try to kind of stay true to our field, saying that, look, it's just one tool, can be effective for lots of things, but that's not the only thing. And it needs to be put in the context of the whole person approach. And I think we did a decent job at that. So yeah, and if anybody have questions about this, we can talk about this more. And Janet, when is the podcast on the book coming out?
The podcast on the book is coming out in October. So we'll share the link when we go live with the podcast episode that we did with Dr. Kogan and his co-author, Dr. Joan Liebman-Smith.
And yeah, so I love Joan. She was
fun.
A professional medical writer. She's great. She's I call her my Jewish mother, my Jewish New York mother. Not that my biological mother is not Jewish, but you know. not like practicing much of anything.
Another one.
But then so anyway.
All
If
right.
anybody's interested, I'm sure we can come and do a little bit. We can bring Joan on at some point. And
Oh yeah, definitely.
so this topic doesn't fit COVID, guys. Even those of you who've seen all this crazy hype, how cannabis is going to cure COVID, there's just so much of that BS going around, and the science in cannabis is so behind. It's fascinating. The science that is available seems to be fascinating, but there's so much more needs to be done. But we can come up with something, and I don't really see cannabis boosting immunity or doing those things, but it's a fascinating tool for certain symptoms. So maybe one of these Fridays, we'll figure out how to talk about it in a more relative term to what we usually talk.
And in answer to your earlier question about who our facilitators will be next week, it'll be Dr. Yan Cheng, who is a research assistant professor at the GW School of Medicine and Health Sciences, and Amy Kassoff, who is the medical director of Access to Integrative Medicine, AIM Health Institute. So Amy will be doing the mind-body practice.
Great. Everybody enjoy. My understanding is we're gonna have a lot of rain. Enjoy the rain.
Yeah. Exactly. Right.
Thank you. Bye.